Hey colleagues, if you are a mental health professional but feel like you don't have an understanding of the basic medicines that are used to treat common mental illnesses, then listen up, because in this series we're diving deep into psychopharmacology for therapists. Welcome back to Psychopharmacology for Therapists. In this series, we've explored the most common medications in mental health with added therapist commentary to help mental health providers be more effective in their work. In this final episode, we're wrapping up our series by discussing antipsychotics. All right, we're going to wrap up this talk of common medicines that therapists should know about with a discussion of antipsychotics. And just as before, I want to start with that conversation. Do you know what psychotic symptoms are? It's important that we do because these medicines, antipsychotics, are maybe the most powerful medicines we have in the psychopharmacology arsenal. And so it's important that, again, we're not prescribers, but we're monitoring for the symptoms that might be the things that trigger the use of these medicines. So let's review some of the things that we consider psychotic symptoms. First, we have delusions, which you remember is a wrong interpretation of the world around you. You're not necessarily hallucinating the girl that's talking to you, but you're convinced that she's in love with you and she's secretly trying to tell you that she wants you to marry her. That would be a delusion. Or the belief that the government is watching you and they're out to get you. There really is a government, and the government really does have spy stuff and really does monitor something about people. But if you're taking it to an extreme place where it's making you paranoid and fearful of the world and you can't live, now it's a delusion. Another psychotic symptom is hallucinations, which most of us are very aware of. It's whenever you see things that aren't there, you hear things that are not there, those things are troubling and they're causing you to dysfunction in life. Another psychotic symptom is disorganized speech, so frequent derailment or incoherent talk. Or another one is grossly disorganized or catatonic behavior. So that sense of just being out of the loop with reality, catatonic, flat affect, just shut down, and those negative symptoms like diminished emotional expression or avolition. So, as we talk about antipsychotics, we're going to talk about them in two generations. The first generation antipsychotics, also called FGAs, were developed in the 1950s when a post-operational sedative, chlorpromazine, also called Thorazine, was discovered to have these antipsychotic properties. Now, Thorazine, by the way, is still prescribed. I've had patients who have had it. But as we're going to talk about in a second, the side effects can be pretty dang dangerous, and so not extremely common. How do these antipsychotics work? So unlike other medicines that might block serotonin reuptake or norepinephrine reuptake, these medicines block dopamine receptors. So it creates a little blockade, and that starts to block that dopamine from reaching certain areas of the brain. So these medicines have multiple names. They might be called phenothiazines or neuroleptics. Now the neuroleptic name is really a reference to their side effects because the side effects can actually be pretty dire. But before we dive into all that, let's try to pronounce some of them. Here we go. So there's fluphenazine, which is Prolixin, haloperidol or Haldol. I do see that one prescribed quite a bit. Loxapine, which is L'Occitane on the market. Perfenazine. Oh, come on, Jim. Of course that's perfenazine, which is Trilofan. Molinodome, which is Moban. Thoridiazine, which is Marilil. And trifluoperazine, which is Stetzoline. You might be thinking, Jim, you only pronounced like two of those right. Fine. I'm at the end of this presentation. I don't hear these words very often because we tend to see the second generations, and that's my story, and I'm sticking to it. So I told you a moment ago that the side effects of first-gen antipsychotics can be pretty powerful. And really quick, I just want to show you what those side effects can be. So one category is called extrapyramidal side effects, and these come in three different flavors. They can be Parkinsonian, which is going to be slowed movement, decreased facial expression, resting tremor, or shuffling gait. They can be dystonic, which is sustained muscle spasms, usually of the neck or shoulder. And by the way, when people experience this, is extremely painful, and they're usually terrified about what's happening to them. Obviously, they don't have control over their body. And akathisia, which is intense feelings of restlessness. But the list continues. Another category of side effects are anticholinergic side effects. These are more physical, like dry mouth, eyes and nasal passages, blurred vision, intestinal slowing, also called constipation, or difficulty urinating, feeling sedated, or feeling sexually dysfunctional. Another category is anti-adrenergic side effects. So, one example of this is what's called orthostatic hypotension. So, this is when your blood pressure drops precipitously when you try to stand up. It can cause lightheadedness or it can cause you to fall and be injured. Obviously, any medicine that's rapidly dropping your blood pressure is potentially dangerous to the patient. A fourth category of side effects are tardive dyskinesia. That can involve involuntary movement. It's when you kind of see people just bopping around or their heads kind of tumbling around, or any other kind of involuntary musculoskeletal movement. And we tend to see this one actually when the medicine is stopped or reduced, not whenever it's being used. Last side effects I want to review with those first generation antipsychotics are just these atypical or rare ones. Again, they're not common, but it goes to show why first gens are not always the thing we want to use anymore. So, a granulocytosis is a very serious blood disorder. It can kill you. Hepatitis is damage or disease of the liver. People can have seizures, not scissors, and they can also experience, get this, lactation. So they can actually have their mammary glands stimulated, and it can cause them to lactate milk, men and women. So you can also experience neuroleptic malignant syndrome. Remember that I told you that FGAs are often referred to as neuroleptics, and this can be very dangerous. It can lead to irreversible coma or death. Now, I know at this point I've probably scared you away from the first generation antipsychotics, but keep in mind they do have a purpose, they are still used, but more often we tend to see these second generation antipsychotics. So, unlike the first gens, which just blockade dopamine, these ones actually blockade serotonin. That's different than SSRIs, which are reuptake inhibitors. These actually block the receptors entirely, and to some extent or another, they may also block dopamine, but they have fewer side effects and especially don't cause that involuntary movement that we've seen in others. So let's practice saying all the magic words. We have aripiprazole, Abilify, acinapine, Saffris, brexpiprazole, Rexulti, which by the way, I do see a lot of Abilify, Saffris, and Rexulti. Cariprimazine, nope, caripromazine, that's it. Nope, cariprazine. Let's go with that. Vraylar. I do see that one a lot. Klonopin, which is Clozaril. Iloperidone, which is Fanapt. I've never seen that one used. Loricidone, Latuda. Yes, I've seen that one. Olanzapine, which is Zyprexa. Yes, see that one a lot. Paliperidone in Vega. Not only do I see that, I tend to see it as an injection. Sometimes patients refuse to keep taking antipsychotics as part of their difficulty of dealing with psychosis and delusions. They think that they shouldn't take the medicine. And so sometimes Invega is used as an injection to kind of buy them longer amounts of time without having to take daily pills. Quetiapine, also called Seroquel, very common. Risperidone, called Risperdal, very common. And Ziprasidone, Geodon, which I haven't seen very much. So, things I want you to keep in mind when you're dealing with your psychotic or delusional patients. First off, you need to keep in mind that part of their disease is extreme paranoia or fear. They have trouble believing the things around them that they're hearing, seeing, and understanding, which means they are going to have deep mistrust. This is where you, as a therapist, are going to be pivotal to their ability to remain medication compliant. Your therapeutic alliance is going to determine whether or not they trust these medicines and whether or not they give them a fair try. But what's also very difficult with these medicines is that it's very common that the first one they take doesn't work. So part of your education is going to have to be teaching your patients ahead of time that the medications they're going to try may not work right away, and the first medicine they try may not work at all. And I usually try to tell them that we're searching for a signature blend of herbs and spices. We're trying to find just the right medicine that matches them perfectly. And you've got to be really encouraging and really motivating and telling them how proud of them you are, that they can continue to give this a try so that hopefully they can find some medication relief. Because without these antipsychotics, people with psychotic or delusional disorders or those kinds of symptoms do not get better. Therapy alone is insufficient. They need the medicine. So make sure that you understand the medicines, you can pronounce the medicines, you have an understanding of what those experiences are like, and you know how to encourage them and prepare them that these things are not going to work right away. Thank you for putting up with me during this presentation and learning with me about the very common medicines that we will see in our work as psychotherapists. If you have any questions, feel free to comment or reach out to me. And by the way, a great book to pick up on this subject is the Handbook of Clinical Psychopharmacology for Therapists. The ninth edition is out now, was published in 2021. Great book just to have in your Kindle or in your bookshelf to refer back to. Everything we talked about in this presentation is in those that particular book, and much more, as well as lots of handouts that you can refer back to at a glance or pass around your clinic among your colleagues. Thanks again for learning with me today. I hope this information was great and useful to you. And remember, being a competent therapist means knowing about the complementing disciplines that support our joint patients. Together, we're going to help these folks. Thanks again and have a great day.